Okay, good evening, everyone. Thanks, Jared and Collins, for the introduction. So before I start my presentations to give you guys an update on the management of CKD, I thought I'll share you some data from pertaining to Australia and New Zealand from NSData. So just apologize. Let me change the slides. So when we talk about renal replacement therapies, it consists of dialysis, kidney transplantations, as well as conservative care. But for today's talk, we're going to talk more about transplantation and dialysis. What happened to your patients when they approach end-stage renal failure? So a bit of history. I practice nephrology in South Australia, so a bit of history in South Australia. So first dialysis was conducted at the Queen Elizabeth Hospital in 1960. We had first four patients, unfortunately, who did not survive more than a year. We have renal transplantation first in Melbourne in late 1964, which was unsuccessful. And I'm very proud to tell you guys that we have a first successful renal transplant in Australia, in South Australia itself, in February 1965. He received unrelated living donor from his father-in-law, and the graft survived for about for more than 10 years. And unfortunately, graft failed due to late rejections, but he survived until 1985. So this is a courtesy for NSData report in 2020. If you look at it,
we just can't see your slide there. Do you have another slide that you can show? That it's just not popping up on our screen.
Oh, okay.
That's the one. Yeah, perfect.
Yep. I think I have to redo the sharing again. All right, so this is a slide from NSData, the report in 2020. This is the latest report we have, and just look at incidence patients who underwent sort of renal replacement therapies from 1960 to 2020. On the left axis, you have the new patients in Australia. Initially, I thought I have their New Zealand colleagues. If you're interested, we have also New Zealand data as well. As you can see, over the years, we are witnessing more and more patients being put on dialysis, being referred for transplants, and the numbers are not going to come down. So you will argue that, look, because nephrologists are just putting on more patients, elderly patients who are inappropriately on dialysis, but data shows us that the majority of the patients, the top line here, aged between 75 to 84, have not witnessed any increase in patients receiving dialysis. But what we can see is the patients aged 65 to 74 that witness increase increasing sort of patients in these age groups undergoing dialysis or transplantations. And also we are seeing more patients because as the population of Australia increases, therefore we see more patients with chronic kidney disease. There hasn't been any change in the younger population as well. So, and this data shows that we are patients who are elderly, who have more comorbid conditions, tend to manage conservatively. And over the years, we have not patients who has complex comorbidities are usually not managed, as I said, managed conservatively. So over the years, the increased number of patients going through dialysis are coming from patients with type 2 diabetes, same as New Zealand, as there are increasingly more better management of glomerulonephritis like vasculitis and other glomerulonephritis, the non-diabetic CKD, the number of non-diabetic CKD entering end-stage renal failure is getting lower and lower. But we are not tackling this cohort of patients where type 2 diabetic CKDs, there are more patients coming into end-stage renal failure. We are not starting dialysis at early eGFR. For the last 10 years or so, patients who started on dialysis, the average eGFR is between the 7th mil per minute. So these two pie charts shows the modality, the renal replacement modality by country. In all the patients in Australia, fortunately, we have almost half of the patients were transplanted. About 40% of patients receive dialysis in hospitals, or we call it hospital-based or facility-based hemodialysis. We can do better by increasing the penetrance of home dialysis, something that we are trailing behind our New Zealand colleagues. So if you look at the survival of patients on dialysis and also on transplantations, if you look at the y-axis is the proportion alive. If you look at if your patients who started on dialysis between the age of 65 and 74, and the survival rate is only 50% at 5 years. So this graph is just to highlight to you that patients who are on hemodialysis or who have kidney transplants, they have a much higher risk of mortality. If you compare to general population, so the blue line represents dialysis cohort, and the green line is general population. You can see the annual death rates. It's much higher, regardless of age and regardless of gender. The gap is better for transplant patients, but again, you can see transplant patients unfortunately also have a much higher death rate because of cardiovascular risk, cardiovascular disease, cancer, as well as infection. So even though transplant patients has a much better survival, much better quality of life, but they do have a much higher death rate compared to general population. We are doing better in Australia-wide in terms of disease donor transplants. There has been steadily increased over the years, and we have not made much gain in terms of living donor. So you can look at, depends on which states you come from. I work in South Australia. We are South Australia's transplant rate is it's sort of, I would say, average. We can definitely do better. But this is just a bit of idea where your state is standing in terms of the transplant rate of dialysis patient in 2019. Not surprisingly, you can see the transplant rate is low in Northern Territory because my colleagues are dealing with a much complicated or disadvantaged group of patients. So before I move on to the next slides, I thought just a bit of tips to GP. If you have any patients, or if you come across any transplant patients, just to remind you that these transplant patients still have a CKD. Transplant itself is not a cure. It's another form of renal replacement therapy, but it is a best form of renal replacement therapy that provides the best, as I say, quality of life as well as survival. The average creatinine at 12 months is about 145 micromole per liter. Possibly because of nephrotoxins like the tacrolimus, cyclosporin, infections, dehydration, etc. Just be careful if you're going to start prescribing new medications. Be aware of drug interactions, and I'm pretty sure if you have any concerns or questions, always just pick up the phone and ring the patient's nephrologist. I'm sure we were happy to answer any question. These are the group of patients who have high rate of morbidity and mortality due to infection or opportunistic infection in this context like COVID-19, and then high rate of malignancy. So before I move on I thought I'd give you this general idea, this data to show you that we have to do something to slow down the progression of chronic kidney disease, because patients who end up on dialysis, not only the affects the patients, it also affects the family, and I clearly show you that this group of patients has a much higher mortality. And I'm very disappointed to tell you that over the last 10 to 20 years, we have made much gains in terms of reducing mortality in cancer patients, in cardiovascular patients, but not in end-stage renal failure patients. So I'm happy to take any questions before I switch to a different presentation. Shall we continue?
Yeah, continue, Chii. That sounds great.
Yep. So before I start, I would like to thank Kidney Health Australia for allowing me to use their slides. So this, I just want to let everyone here know that the Kidney Health Australia has published new management guidelines for primary care in 2020. So it's the most up-to-date guidelines these slides are, most of the slides that I'm giving today, you can find it, the information you can find it from the guidelines. So just Google Kidney Health Australia and most of the information are available in there. So the aim of this presentation is, number one, to recognize the importance of screening high-risk individuals for CKD. As I said before, unfortunately, by the time I see the patients that I get referred to, it's too late for me to do anything. I'm not trying to imply that late referral is an issue. Over the last few years, I believe late referrals has been is less now. GPs are actually has been referring early to my clinics, to my colleagues' clinic. But again, what I'm trying to say is that if you intervene early, you will make an impact in terms of a CKD progression. Currently stage the CKD using the eGFR urine ACR results, and what are the ways to manage CKD patients, particularly diabetes, because as I said, this is the most commonest cause of CKD in Australia. So yeah, it's really, yeah. Please Google the Kidney Health Australia's the handbook is free to download. I thought it's good to start off with a case. Peter might be one of the patients that you commonly come across in your surgery. He's a 62-year-old man who works full time in a business management. He presents to you with a lower upper respiratory tract infection, and it's here for annual flu vaccination. So a bit of background history. He smokes one packet a day for the last 40 years. He consumes about 7 to 10 drinks per week. He follows a diabetic diet. I don't know what that means, but he has a type 2 diabetes diagnosed 12 months ago after presenting with polydipsia, and currently he's not on any medication. So you performed some examinations and reviewed hypertension with a blood pressure of 160/90. It's obese with a BMI of 31 kilogram per meter square, and chest findings consistent with bronchitis, but no signs of chronic obstructive airway disease. So yeah, I mean, this is supposed to be interactive. Is Peter at increased risk of kidney disease? Definitely yes. So these are the risk factors for the development of chronic kidney disease. Diabetes patients, patients with existing high blood pressure, any history of heart failure, because it predisposed patients of getting cardiorenal syndrome, particularly patients with reduced ejection fraction. Obesity is definitely one of the risk factors. Age 60 and above. Any family history of kidney disease that will predispose patients of getting familial nephritis. History of acute kidney injury is also a known risk factor for chronic kidney disease, depending on the severity of acute kidney injury. For patients who had a history of AKI requiring temporary dialysis, these are the patients who end up developing CKD in the near future. So I tend to monitor this patient at least once a year. Smoker, you can see that these are the common risk factors for cardiovascular disease as well, and of course Aboriginal and Torres Strait Islander patients. If you go through the case for Peter, Peter does have a couple of risk factors. He has diabetes, hypertension, he's obese, he's a smoker, and I think he had at least 1, 2, 3, 4, 5 risk factors. So it is very common in Australia, and it's 1 in 10 patients, 1 in 10 Australians aged 18 years and above have risk factors of CKD and also reduce kidney function. It's common. It's twice as common as diabetes, and however, lots of patients are unaware of the diagnosis because, just like hypertension, patient is usually asymptomatic. By the time patients presents with symptomatic chronic kidney disease, that's the time when they will require dialysis imminently. The reason why I'm giving this talk is because if CKD is detected early by the primary care doctors, it can and managed appropriately, you are able to make an impact in terms of reducing the deterioration of kidney functions by as much as 50%. I will show you the data, more data in my following slides. Early management plays a big role, and again, the management of a CKD is quite similar to the management of cardiovascular disease, similar to the management of diabetes. So it's not a completely different set of management. It's often overlooked, as I said, because it's usually asymptomatic unless you do a lab test or check for urine albuminuria. You will be dealing with this group of patients. Unfortunately, I see patient in this group, stage 4, 5, and definitely dialysis and transplant patients. But by the time I see these patients, it will be too late for me to intervene or slow it down. But you guys do play a big role because these are the patients that will come to you for hopefully for annual review or for half-yearly review because of the diabetes medication, prescriptions, blood pressure monitoring. That's why it's important for you guys to be able to identify the risk factors and intervene as early as possible. So Peter is hypertensive, and you decided to do a blood test and review a creatinine of 118 micromole per liter. That translates to eGFR of 55 ml per minute per 1.73 meters square. And it's reduced, and the urine ACR of 20.7 milligram per millimole. So that will translate to about 200 milligram of albuminuria a day. So, and it's elevated. So does Peter have CKD?
Yes.
Yes. Yep. Maybe.
Oh, you need to
maybe
3 months. Yeah.
Exactly. Yeah. So look, Peter definitely has CKD, but the definition of CKD is when the eGFR is less than 60, that is present for more than 3 months, with or without any evidence of kidney damage like albuminuria, hematuria after exclusion of urological causes, any structural abnormalities on kidney imaging tests like polycystic kidney disease, medullary sponge kidney, as well as any pathological abnormalities. So Peter, as the colleague has mentioned, I would suggest to repeat the blood test again in 3 months' time, as well as the urine test. And if patient still has less GFR of less than 60 or evidence of albuminuria, then you can classify Peter as having a CKD because he is at risk, as I mentioned. So about 40% or 20 to 40% of patients with type 2 diabetes will develop some form of nephropathy, which classically happens in 2 stages, like early nephropathy or overt nephropathy. Don't be surprised. I've seen patients with type 2 diabetes without any evidence of albuminuria, but when I do a biopsy, it sometimes shows, what it shows is just ischemic changes, diabetic changes. So there are a good small group of patients who developed diabetic kidney disease without albuminuria. So this is a rather busy chart, but allow me to show you that in the first phase, at the beginning of diabetes, early stage diabetes, the kidneys will go through a phase of hyperfiltrations, where if you do the biopsy, the biopsies, it will reveal sort of glomerulomegaly or glomerular hyperfiltrations. This is the stage where you will start noticing albuminuria. Usually patients' albumin concentration in the urine will start going up. And the only way you can detect these groups is by doing a urine spot albumin creatinine ratio. Kidney Health Australia recommended morning void. for me, because you're going to repeat the test again in 3 months or 6 months time anyway, but it doesn't matter whether if it's a first void. Because if you do the renal, if you check the kidney functions, most of the time the creatinines will be, if you look at the creatinines, sorry, if you look at the GFR of the kidney is usually high or normal. So the blood test will give you a normal creatinine level, or sometimes a low creatinine level, giving you the false impressions that there's no evidence of diabetic kidney disease. But if you check the urine albumin creatinine ratio, you would not be surprised if patients have signs of microalbuminuria. Just to let you know that the dipstick itself will not be sensitive enough, because for the dipsticks to show 1+ positive for proteins, you have to be more than 300 milligram per day. By the time you start seeing eGFR drops down to 90, that's the time patients have already lost more than 50% of the nephron mass, therefore it's important that we catch this group early and we can do something about it. Does the diagnosis of CKD have any implications for Peter? Definitely, okay, because studies have shown that patients with CKD have a much higher cardiovascular mortality. If you look at this, the graph on the left-hand side, it's divided into different groups based on the severity of albuminuria. The red line represents the macroalbuminuria groups, and the lower the eGFR, the higher the risk, which is the adjusted hazard ratio. And not only that, CKD also increase your risk of developing end-stage renal disease, like i.e. approaching dialysis and transplantations. And the higher the amount of albuminuria, or the lower the eGFR, the higher the risk. And this is not typo, yeah. This is hazard ratio of 8,192. So CKD is harmful. As I mentioned before, so far we have not made any successful sort of dent in terms of survival benefit in CKD cohort, and around 65 patients of Australians die every day with kidney disease, which is more common than breast cancer, prostate cancer, and road traffic accidents. So it is it's a link. As I said, the cardiovascular disease, diabetes, CKDs, they all share the same goals and treatment management. So it's basically what I'm trying to say is you guys have been dealing with this day in, day out as your bread and butter. So it's just for you. Now the only thing to learn from this presentation is to be aware of some of the risk factors and what are the latest evidence in terms of the management of this group of patients. Sorry. So what would look, if I, sorry. Yep. This is basically this slide. It's again telling us what I've just mentioned. Please perform a blood test, a urine test, looking for albumin creatinine ratio, as well as checking the blood pressure. If you have patients who has risk factors, and the Kidney Health Australia recommends doing a kidney health check every 1 to 2 years. I would say every 1 year, depending for Peter's case, because he does a couple of risk factors. This is CKD detections in Aboriginal and Torres Strait Islanders peoples, and this you will have to screen at a younger age, between age of 18 to 29. Without any CKD risk factors, to screen for CKD, because they do have a higher risk of lupus nephritis compared to the general populations, and for patients above age of 30, as well as any other risk factors, please check it frequently. I'm pretty sure you guys are familiar with this table. It divides CKD into different stages, 1, 2, 3, 4, and 5, based on the GFR, as well as albuminuria stage. It's color coded because it's not to cause any alarm to the patient or to practitioners, but basically it's color coded just to give you a, because it's correlates with the action plans based on the handbook. If you download the handbook, it will tell you if your patients fall into the orange category, this is what's these are the goals of management and how often you repeat the test and etc. So as I said, it's all available through Kidney Health Australia website. So this, so Peters, once we know the results, Peters falls into CKD class 3A because he has a microalbuminuria and his eGFR is, I believe, is 55. Okay, so why do we stage it? Number one, it will help you guys to manage the patients appropriately based on early detection and management. Patients is aware of the diagnosis and also help them to engage in the management of chronic diseases. So our aim here is to slow down the progression of CKD as well as to prevent complications from it. What we are trying to do, it's by your help and also by the help of your allied health team, like dietitians and nursing staff, is to reduce the slope of this the lines, the decline of the GFR over time, just reduce the slope of the declines, and just to what I tell my patient is to slow it down so that by the time you reach eGFR of 20 or 10, then you will be, more than the age of 80, and dialysis and will not be options that it's sort of attractive to the patient. I won't go through this. You can find this from the action book. So what would you do next once you have classified Peter as stage 3A CKD? So do you advise lifestyle modifications, address his hypertension, consider adding an oral hypoglycemic agent, you do more tests, refer to an endocrinologist to manage diabetes, or you refer to a nephrologist. So yep, lifestyle modifications. That's one of the biggest impact for Peters. We're going to address his hypertension, and we're going to talk more about the hypoglycemic agents. So these are the advice that I'm pretty sure you will give to almost of the patients who has cardiovascular risk factors, is to quit smoking, a low salt diet, a low calorie diet to reduce his BMI, a reduction in his alcohol intake, as well as an exercise program. This is slides from KDIGO that incorporates different cultural backgrounds that show you the portions, the size of the portions of the meal that patients should take. Unfortunately, we live in a world that we're full of abundance, with lots of with abundance. Therefore, the portion size it's way too much for most of our patients. Recommending the physical activities, physical work for more than for sort of at least an hour a day would also help to reduce the risk of the patient. So Peter has hypertension. What blood pressure target should aim for? Anyone or
the lower the better.
The lower the better. Yep. So 110/60 is right.
As long as he's not symptomatic with it, that's fine.
Yep. So it's a good point. If you look at the sprint trial, which is a huge randomized control trials that was published, I think 2 to 3 years ago now, that shows that lower blood pressure control actually do reduce the risk of cardiovascular mortality. But again, you have to be careful that the patients that were included in the trials are much younger. What I mean by younger, it's sort of Peter's age group. I'm not asking you guys to aim for 110/60 for all elderly patients, because these are the patients who end up having a fall in the hospital. So, but for Peter, For the sake of discussions, the Kidney Health Australia has recommended that maintain a blood pressure of less than 130/80. But I agree with you that if I can get it down lower, but not causing Peter to be symptomatic, I will try to achieve for that, because there is evidence behind it.
Chii, we've got a question there. If his blood
yes.
pressure is already 125/80, would you put him on an ACE inhibitor?
Yes. So in Peter's case, I'll definitely put him on ACE or ARB, because it's a first-line treatment for diabetic patients or even CKD patients with albuminuria. What I will do is I will switch, calcium channel blocker or maybe beta blocker, depending whether there's any other indications with ACE inhibitor or ARB. Okay. So I always tell my patients, look, we do commonly come across patients who end up taking, more than 4 to 5 different types of tablets, and I tell them that, look, if you really want to cut down your medications, then you have to work on your lifestyle, because by restricting, sodium intake to less than 2.4 grams per day, that is equivalent to one antihypertensive tablet. One antihypertensive tablet, depending on the agent, will reduce your blood pressure by 4 to 5 millimeter mercury. But if you do the right thing, like weight reduction, sodium restrictions, it is equivalent, is effective as one tablet. DASH diet. DASH is basically a Mediterranean diet. The DASH is from the trial named DASH, but basically it's fruits, veggies, low saturated, low fat diets. Again, you can see, it's also as effective as a blood pressure tablets. Physical activity. Look, it is difficult. We are dealing with counseling and lifestyle modifications. But I always like to show this graph show this table to my patient, is that if you really think about pill burdens, let's look at what you can do. So you follow up. You see Peters again 3 months later. He has taken on board your advice, which is fantastic. He's working hard on his lifestyle. You put him on ACE inhibitor for hypertension. He's quit smoking, excellent, and you put him on metformin, which I think is an appropriate first-line agent. However, he's put on weight. It's 2.8 kilos, and his HbA1c is 8.7%. Peter is young. He's independent. He's active. I would aim for a much lower HbA1c. I would aim for 7, at least for him, and his fasting glucose is 9.2. So you decide with Peter that metformins, you have to be more aggressive in terms of the management of his diabetes, which I believe everyone's here agree. Which agent would you choose? Sulfonylureas like glycoside, SGLT2 inhibitors. The examples would be like canagliflozins, dapagliflozins or empagliflozins, DPP4 inhibitors like gliptins, dipeptidase, linagliptins, sitagliptins, and GLP-1 receptor agonists will be like glucose, exenatide, semaglutides. I have to pick on you again. Which one would be your next agent?
Well, Lachlan says it's sulfonylurea. I'd probably go the SGLT2 TI inhibitors. The
SGLT2, yeah, sodium glucose link transportase 2 inhibitors. The sulfonylureas will be not a, I mean, it's losing favor now because sulfonylureas can increase the risk of hypoglycemia, and also it's associated with weight gain. And there's not much evidence in terms of organ protection. So therefore, sulfonylureas is actually losing a bit of becoming less favorite, I would say. Definitely SGLT2 inhibitors. There's so many trials, and which I will show you a summary of them. Don't worry, and as well as GLP-1s are getting more and more attention, because GLP-1, particularly GLP-1, receptor again can be associated with significant weight loss, which will help Peter's condition actually. So for today's discussion, let's say you were going to choose SGLT2 inhibitor, maybe. So just a bit of this slide is just to remind you the oral hypoglycemic agents, how they work. So you have metformins working to reduce insulin resistance and increase hepatic glucose, decrease hepatic glucose overproduction. The SGLT2 inhibitors acts on the proximal tubules of the kidney, so it actually inhibits sodium glucose transporter. So it basically inhibits sodium being reabsorbed as well as glucose being reabsorbed into the kidney. So therefore, because you're preventing glucose being reabsorbed into the body, you are inducing glycosuria. And also you're inhibiting sodium being reabsorbed. So you're also inducing what we call natriuresis. Basically, it is a form of diuretics. Whether or not this actually translates to weight loss, I believe so, but some believe that there's other metabolic component in it. But if you look at the trials, patients tend to lose, about 3 to 4 kilos in this, 3 to 4 kilos in weight, I believe, because it's a diuretic effect. And just to be careful, if you put someone on SGLT2 inhibitors, if they are already on multiple diuretics, you can potentially potentiate dehydration. Anyway, I'll talk more about in details later on. You have the DPP4 inhibitors and GLP-1 receptor analogs. These two agents increase the incretin level, therefore stimulates insulin release. So if you look at the timelines, for the last sort of 2-3 years, the diabetic and the nephrology and the cardiovascular field has been sort of inundated with lots of trials and many trials coming from SGLT2 inhibitors, not only looking at cardiovascular outcomes, but lately there are trials to show that there are benefit in renal outcome as well. So this is a summary. I'm sure you guys are quite familiar with all these trials. This is just a summary of SGLT2 inhibitors with cardiovascular outcomes. So it was, I think, the CLARE-TIMI and POURAGE came out, I would say, 7-8 years ago now, looking at patients with type 2 diabetes, and the main primary outcome is cardiovascular, and the renal outcomes are secondary endpoints. So they are not primary, but what they have found is during the study, SGLT2 inhibitors have been associated with reductions in main renal outcomes. The CLARE-TIMI looks at dapagliflozins, like 47% reduction. POURAGE, it's look at empagliflozins, about 39% reduction. So this makes the nephrology world very excited. It also makes the drug company excited as well. So therefore, what they have done is to perform more studies, but instead of looking at cardiovascular outcomes, we now look at renal outcome as the primary endpoint. Credence, which the paper was published 3 years, I keep forgetting it's 2022, it's 3 years now, in Sydney by the George Institute. They've included about 4,000 patients with CKD and type 2 diabetes. All patients have type 2 diabetes, and the renal outcomes consist of a composite of end-stage kidney failure, doubling of serum creatinine, renal or cardiovascular death. So these are all hardcore heart renal endpoints, and the study have completed, and we'll show you the results in the next slide. Tapa CKD came out last year, again 4,000 patients, but they've included, interesting about this trial is that they've included CKD patients with and without diabetes. So no doubt, two-thirds of the patients are diabetic, but 1/3 of the patients are non-diabetic. And in these non-diabetic patients, a majority of them are actually IgA nephropathy. And you must have urine ACR between 200 to less than 5,000 milligrams per gram, which is in the category of microalbuminuria and above. And again, looking at heart renal endpoints, end-stage kidney disease, cardiovascular death, and 50%, more than 50% of sustained eGFR decline. That study was completed was published 2 years ago, and I'm waiting eagerly for MPAS CKD, which look at, again, they included CKD patients with type 2 diabetes, type 1 diabetes, as well as other causes. And expect this study to complete this year. So this is a bit, so this is sort of a clear illustration in terms of what those trials have covered. If you look at Canvas, Emparage, 7-8 years ago, these are the papers that only included patients with very mild kidney disease. What I mean by mild is, their eGFR is between 60 to 90, and they have basically sort of normal or no albuminuria. So what we are interested in is this group of patients where they have eGFR between 25 or 30, between 25 and above, 25 and above, and a wide spectrum of in terms of albuminuria. So we have Credence reporting in this group of patients, TAPA CKD somehow similar to Credence, and MPAS CKD with a much broader presentation. So so by combining both the papers that have been published as well as other papers that have included renal outcome, basically not only as a primary endpoint but secondary endpoint, if they look at all the cardiovascular, renal, and heart failure outcomes, which can show that the risk ratio it's 0.81 for cardiovascular death, non-fatal MI, non-fatal stroke, 61 risk ratio of 0.61 is very significant for hospitalization for heart failure, which is 40% decrease in hospitalization heart failure, and 30% decreased risk of renal composite outcome, like reaching end-stage renal failure. So for diabetes management in CKD, apart from those lifestyle modifications that I've mentioned, I think the first-line therapy, no doubt, will be still metformin, which I agree, but just be careful if you're going to start someone on metformin with a reduced eGFR. You might have to reduce the dose if the eGFR is less than 45. And if the eGFR is less than 30, it depends. I will not discontinue it, but it depends on if the patient is like Peter's age and has been educated to sort of to hold the medications when they are fasting or when they are unwell. I will still continue at a lower dose of metformin, but definitely if their eGFR is less than 15, or if there's a high risk of acute lactic acidosis, then I will stop the medication. SGLT2 inhibitors, be careful if you, so far the studies have shown that the patients that included in the study, have eGFR of more than 25 or 30 mils per minute. So I'm still waiting eagerly for data of less than 30, but at this stage, the recommendation is not to initiate. And I will, let's say if I have a patient who is on SGLT2 inhibitors with the eGFR of, let's say, 40, and over the next 2-3 years, if the eGFR drops down to less than 30, I will still continue on the medications. I will not stop it unless patients develop side effects, and I only stop it when they go into dialysis. GLP receptor agonist, I think it's a good idea, particularly if you are if you want to achieve weight loss or if you want to achieve a HbA1c reduction. Just to be aware that SGLT2 inhibitors, even though it's it has renal protective effect, but the effect on the effect on HbA1c reduction is actually less as the eGFR drops. So if you're going to rely on the SGLT2 inhibitors to reduce the HbA1c in Peter's case, the effect might be sort of a bit disappointing compared to other agents like GLP-1 agonists. Because as you can imagine, with CKD, the tubular functions get affected, and therefore the SGLT effect is less. And followed by those non-other options. So this is This is a graph that I find it interesting because I just want to before I elaborate on this slides, I just want to let you know this is based on extrapolated data from the Credence trial. So I managed to go through the Credence the data, and the Credence trial was the duration of the trials was around 2.5 to 3 years. So what we have done is, if we extrapolate the data and extend it to 10, 15, or 20 years, what will happen? So what I would like to show you is that if you have a patient at the age of 63 and who starts with an eGFR of 56 and is randomized to take placebo, which is the yellow line, or the canagliflozin, which is the blue line here. So the Credence studies have shown that canagliflozin slowed down the progression of CKD. So you can see that for patients who are on placebo, the rate of decline of eGFR is it's around 4.59 ml per minute per year. And if you take if patients will end up on canagliflozin, the average decline is about 1.85 ml per minute per year. So if this is, again, let me stress, it's extrapolated studies. We do not have any long-term data from these two medications because, but I'm sure that we'll have the data soon. But if you extrapolate the data, what you can see is patients who are on placebo, by the time the patient reaches, it takes about sort of 10 years to reach the eGFR of 10. So that's the time that we usually start someone on dialysis. But if for patients who are on canagliflozin, by the time it reaches eGFR of 10, the patients will be 25 years later. So 25 plus 56, that's about 80. Patient will be 81 years. So again, I'm not saying that age is a contraindication for dialysis, but by the time patient is 81, dialysis will not be a feasible sort of treatment options because of its demand on patients' quality of life. This is a bit of summary. I'm not going to go through much in details, but just to show you that the comparisons between the different type of oral agents. This is the GLP-1 agonist, again, have shown to be cardiovascular, has evidence of cardiovascular protection, weight loss, significant weight loss, which is much more impressive than any of all these oral agents combined. It's low risk of hypoglycemia, but of course, if you take it with like glycoside or insulin, it will increase the risk of hypoglycemia, same as SGLT2 inhibitors as well. One of the disadvantages of GLP-1 agonists is it's a subcut administrations. There's no oral formulation, and there's always a risk of causing pancreatitis, just because it increases the incretin level and stimulates the pancreas to release insulin. So the DPP-4 inhibitors also has an increased risk of pancreatitis too. I think the glitazones are slowly, they are again losing its favor because it's can be associated with heart failures, and in terms of organ protections benefit, it's lacking compared to others. So the GLP-1 receptor agonists this is the MACE outcomes, and all-cause mortality have shown to reduce, has again some cardiovascular benefit. However, the benefit for renal outcome is less robust compared to SGLT2. So we're still waiting eagerly for more data to come out in regards to renal outcome. But so far, GLP-1 agonists, it's lacking. So it depends on the patient in front of you. What are you trying to achieve? If patient have stage 3 kidney disease with albuminuria and is already on the ACE inhibitor on ARB, then SGLT2 inhibitors will be the best so next line agents, because you're trying to protect the kidney. But if you have obese patients with high HbA1c and you really want to try to achieve weight loss, then GLP-1 might be your next agent of choice. The glycemic targets in CKD have to be individualized, just like how you individualize the target blood pressure in this group of patients. For elderly patients or patients who had multiple comorbidities, again, maybe you kind of have to relax these HbA1c a little bit. But for most of my patients who already has on dialysis or preparing to as a pre-dialysis stage, I tend to relax the HbA1c because they tend to go into they tend to get hypoglycemia, and hypoglycemias end up causing can be more dangerous than hyper. But for Peter's case, I would definitely aim for a much lower HbA1c. So after listening to these presentations, you have decided to put Peter's on SGLT2 inhibitors, and his creatinine increase, I believe, was 108 or 105 to 140 micromole per liter. Should you stop the medicine? Have anyone of you familiar with these medications, or have you prescribed this medication before?
Not commonly.
Not commonly, yeah. So the answer is no, because we call the phenomenon as initial dip in eGFR. This is not specific to dapagliflozin. It's actually common across all SGLT2 inhibitors. It's a class effect. You will get this initial dip. The reason for this initial dip is not because of damage to the nephrons, but what it does is it's SGLT2 inhibitors reduces the tubular feedback to the glom. Therefore, it reduces the intraglomerular pressure. It's just like an ACE inhibitor. I'm not sure if you at the beginning, when you first start someone on the ACE inhibitor ARB, you also expect an initial dip in eGFR because of the hemodynamic change. So this phenomenon is also seen in SGLT2 inhibitors, where the tubular feedback is enhanced. Therefore, the intraglomerular pressure is reduced, and the hemodynamic changes causes the GFR to drops a little bit. But as the intraglomerular pressure drops, it therefore reduces intraglomerular hypertension and intraglomerular fibrosis, and therefore progressive kidney disease. And you can see the dip is usually it's actually, the studies have shown that if you stop the medications after the dip, the GFR will actually goes back up again. So it's actually not a permanent dip. And over the years, what we want to see is the rate of decline is GFR. It's much less compared to placebo. Okay, so don't be too alarmed if you witness initial dips or initial dip in the GFR or increase in the creatinine. I always if I start these patients on with a IgA nephropathy, I always tell the patients you expect a bit of 30% increase in your creatinine in the first month of taking that medication. That is common, and that means that the medication is working. But what we want is the long-term effect, which is renal protection. So yeah, I will tolerate up to 30% increase. And again, if there's a drop in more than 30%, you might have to think about whether or not patient is taking too much diuretics, or whether there's any other cause of it. So I've present to you all those data in regards to the benefit of SGLT2 inhibitors, but but it's now the time to also to mention about potential side effects, and what are the things to watch for. So for patient selections, I find this is a good table, a summary of what I've mentioned. Patients will be eligible if eGFR is more than 30. Patients will get more benefit if they have evidence of albuminuria, or if they have heart failure. Potential contraindications are like genital infections, because it induces glycosuria. Therefore, you can imagine it increases the risk of genital infections. And I've seen the patients who unfortunately developed severe necrotizing fasciitis around the area. Yeah, so just make sure you check for all these risk factors before putting patients on on these medications, increase the risk of UTI as well. There are certain trials have reported increased risk of diabetic ketoacidosis. So what I usually tell the patient is if they are fasting for any procedures or if they are unwell, I always tell them to hold the medication for a couple of days. Once they feel better, restart the medication again, just like metformin, just like the ACE inhibitor or ARB. Foot ulcer, this is seen in one trial, but not seen in other trials. And again, in terms of immunosuppressions, we are still awaiting for more data in regards to this group of patients. But there's lots of interest, and there are a few randomized control trials going on at the moment for taking for giving SGLT2 inhibitors in transplant patients. So I don't think we have canagliflozin in Australia. I'm not sure why, but we have dapagliflozins and we have empagliflozins. Dapagliflozins is 10 milligrams. You don't have to increase the dose. It's just one tablet a day. Empagliflozin is also once a day, but I think there's a higher dose is 25 milligrams. As I mentioned, sick day protocol, pre-operative care, and the foot care. Assess for any adverse effects, like whether or not patient is reporting excessive diuretics, and make sure you warn the patients about the risk of UTI. The risk of hypoglycemia is less. It's actually has not been seen in the trials, unless for patients who are already taking insulins or sulfonylureas, and volume depletion, as I mentioned before. Yeah. So I have a patients who end up getting some polyuria and hypotensions, end up having to stop the thiazides and continue on the SGLT2 inhibitors. That's why I said I've mentioned before. If this patient also has heart failure, these drugs will give you the additional benefit of diuretics as well as organ protection. Should Peter be referred to a nephrologist? If you have any concerns, or if the decline of the GFR is much faster than you're comfortable with, definitely. But at this stage, I say maybe no, or maybe you can hopefully the guidelines will give you some idea on how to continue to manage Peter's case. If the urine ACR continues to increase or they show no improvement despite on ACE or ARB, or any evidence of microscopic hematuria, referral is usually recommended because we might be dealing with dual pathology, diabetes plus or minus IgA in Peter's case. Who needs to see a nephrologist? Based on the Kidney Health Australia guidelines, it's anyone with eGFR less than 30, persistent significant albuminuria, or any sustained decrease in GFR of 25% or more within the 12 months, or if the rate of decline in GFR is much steeper. If you have any concern or doubts, please feel free to refer, or anyone with uncontrolled hypertension. So I'm getting, this is the last few slides. Hopefully I have given you enough evidence, given you data to convince you that you guys are the front lines in battling this CKD. If you can make an impact then it will definitely slow down the progression of kidney disease and the amount of patients needing dialysis. I believe you work closely with a group of allied health professionals and with your nursing staff as well as dietitians, and to deliver the best care for your patients. I'm not going to go through all this. I think you guys are all very familiar with this. Okay, any question?
Chii, there was a question in the chat about ACE inhibitors and whether they should be given in the morning or the night time. Is there a difference between the renal protective effect on the time of day it's given?
I don't. Good question. When I first start ACE inhibitor, I usually tell the patient to take it at night because this is just to reduce the chances of postural symptoms. look, by the time patient is used to it, there's no difference between whether it's a day or night time. But when I first start the patient, I usually start it at night.
And the other thing that...
Yep, there's one thing is those patients. Remember, I showed you the summary of the benefits of SGLT2 inhibitors on renal protection. Those benefits are on top of patients who are already on ACE or ARB. So most of the patients who are included in the trials, I would say more than 90% of them are already on the ACE or ARB. So ACE and ARB will still be my first choice in terms of organ protection, in terms of blood pressure control, then followed by SGLT2 inhibitors. Yeah, sorry.
Yeah. You know, that's right. And then the third medication the guidelines talk about is the statins. And, you know, everyone over the age of 50 with CKD should be on a statin. Is that your recommendation as well?
Look, at this stage, statins, I tend to be more aggressive in terms of the management of risk factors, as I mentioned in my start of the talk. I am not too, I would actually keen to push on lifestyle modification first. I would usually warn the patient that, look, you know, if things are not heading in the right directions, then medication is something that you have to rely on. So sort of yes, that if patient have persistent hyperlipidemia despite the health lifestyle advice, yes.
Yeah.
Because the patients with CKD, they are much higher risk of cardiovascular event. Yeah.
Yeah.
But you don't have to. You don't have to put them on. You don't have to put them on like humongous, because I you know, compared to patients who after seeing my cardiology colleague, you know, they are you know, usually they present with stents or with non-STEMI. They are, you know, they are put on rosuvastatin 40 milligram bang straight on. You know, most of the patients would end up getting side effects like muscle ache and things like that. So, but for CKD patients without any established cardiovascular disease, you can increase the dose slowly. You don't have to, you know, hit them hard straight away with a big dose. I think this is a time where patients tend to get a lot of side effects and all this myalgia. Yeah.
Can I just ask, the evidence you presented around the protection of the renal function in patients that don't have diabetes was also quite impressive. How far away do you think we are from having these drugs licensed for management of CKD? Because I can see where I would use this. This would alter the way I sequence my diabetic therapies for patients at high risk of kidney disease. But for a patient without diabetes, these drugs are very expensive, and obviously there's a significant benefit there. Do you think they're likely to get PBS funding?
As we speak, AstraZeneca has introduced a new program where non-diabetic patients are eligible to these medications, but only if the medications can be if the medication is prescribed by nephrology. Sorry. So look, it's I cannot predict who will win the general election, but I believe if once we have the EMPA-REG data, that is another major trials that enroll CKD patients with diabetes and without diabetes. If that EMPA-REG data is consistent with the DAPA CKD data, I'm quite confident that the PBS will eventually include SGLT2 inhibitors for non-diabetic patients. But again, this is my prediction. It all sort of there's a lot of other factors that I can't control in terms of, you know, political influence and the cost and things like that. Yeah. But
will private health funds pick it up?
So if like I'm not sure about private health fund though, but I do have patients who are eligible. They are actually getting the medications sponsored by AstraZeneca. But that medication is only eligible for to nephrologists.
Yeah, sure.
A few more questions in the chat box. What's your advice about using non-steroidal anti-inflammatories in the early stages of CKD?
Intermittent use. The advice is to avoid it as much as if possible, because NSAIDs, not only it also affects the hemodynamics of the perfusion to the glom, it can also be associated with protein, with what you call that, proteinuria as well as FSGS. So I mean, look, yes, most of the time, if NSAIDs it's indicated and it's really make an impact on the patients, what I'll tell the patient is, take it only if absolutely necessary, and take it for maximum of 2-3 days, and then stops, and then don't take it as daily.
And one
and just be careful if you. So just be careful if your patient's already on ACE, ARB, as well as thiazide, as well as SGLT2 inhibitors, taking NSAIDs on top of it is going to increase the risk of acute kidney injury. If you heard of triple whammy, so these are the sort of the combination of medications that, if the patients are well, that's okay, but if the patients become sick, and all this combination of medication was just just cause the kidney function just to dive down.
What we see commonly is patients with gout, and they've got acute gout and the eGFR maybe 42 or something like that, and do you pick an anti-inflammatory, or do you pick prednisolone, or do you pick, colchicine? They're all nephrotoxic. Is there a particular one you pick?
No, I think colchicine would be a reasonable option. Colchicine's, it's for a couple of days, 2 days, it's not particularly nephrotoxins unless patients end up getting diarrhea and volume depletion. So colchicine, I think it's a reasonable choice. And a lot of my colleagues who also concerned about starting allopurinol in CKD patients. Again, there's no evidence to imply that. So if most of my patients have hyperuricemia, if they keep getting gout, I will actually put them on a low dose allopurinol and slowly build up the dose for my CKD patients.
Yeah.
Prednisolone. I would, NSAIDs, colchicine, then maybe followed by NSAIDs. Prednisolone, I'm not really a fan, particularly if it's a diabetic patient. It just end up causing their sugar to go up, So, but if you have like for my patients that I see in the clinic, if the eGFR is less than 15, less than 10, yes, steroids it's unfortunately my only choice.
Yeah. And just from the chat, again, obviously COVID's around these days. Is there an eGFR level where you would recommend someone get the active treatment of COVID or COVID?
When you say active treatment, are you talking about those
monoclonal antibodies?
Oh, yeah. Yep. It depends on the age. Depends on the age of the patient. Also depends on whether the patient is fully vaccinated. If you're young, fully vaccinated, even though you're on dialysis, patients will not qualify for the monoclonal antibodies infusion. But if you are, I think above the age of 60, if I'm not mistaken, or partially vaccinated, then yes, we'll give you the infusion. And by the way, we also take into consideration when was the second dose and whether the patient had the third dose. So because for kidney disease patients, 3 doses are considered as a one whole regime, which is fully vaccination.
Yeah.
Does it make sense?
Another final question from the chat was about nephrology referral. Is there an age ceiling on nephrology referrals? We have some doctors that just work in aged care.
If I put an age, I think I'll get the stare from my colleagues from geriatrics. I don't think there should be an age limit, but I think more of patients' underlying comorbidities and whether patients independent. Look, I mean, I have not young. I mean, I have a very well sort of 85-year-old patient who still active, and he, I mean, I still see him for EPO, and I might consider him for home dialysis if the times come, because it's just so, he has not much comorbidities. He's active, but again, age is not. It's just a bit of I can't really give you that cutoff. Sorry.
That's fine. Well, thanks so much for tonight. That was great. If there's no more questions, any more questions, guys?
You can unmute and
talk if you want, or you can chuck it in chat. If not, thanks so much for your time, Chii. That was great. It was a really good overview of chronic kidney disease and a good understanding of where it all leads to and the new medications that are coming out. Really appreciated your time.